it's very common for individuals who maybe don't have a lot of knowledge really in this specific area to feel like when there's a diagnosis of stage 4 lung cancer, a disease that has spread throughout the body, that our goals of care and our goals of treatment really should shift toward palliation, toward perhaps minor extension of life. And that has really honestly been the attitude, the approach, the opportunity for many, many decades. And that's not only been the perspective of people outside of medicine, but even within the thoracic surgical community and the thoracic medical oncology community, our treatment of patients with advanced lung cancer has focused on quality of life and really has looked for small little differences that we can make toward extending their life. And it's only really in the last 10 years or so that we have seen huge progress in ways that we can find groups of patients who may benefit from a more aggressive approach. And I think a lot of our change in understanding how to find those right patients began with some of the really important trials in oligometastatic disease. And so for folks who maybe aren't familiar with these terminology, we tend to think about oligometastatic disease as being a few sites of metastases and polymetastatic as being many sites. And oligometastatic disease, for the purpose of our clinical trials here at MD Anderson, as well as the clinical practice guidelines recently put forth by the Society of Thoracic Surgeons, has really stuck to a definition of 3 or fewer sites of disease, with all mediastinal lymph nodes considered one site of disease. And it's through this group of patients, through this very selected group, that we were initially able to see really a dramatic improvement in results with any type of local therapy consisting of surgery or radiation. And I think, I like to view oligometastatic disease really as kind of the gateway entry for thoracic surgeons to be involved in the care of patients with stage 4 disease. But as I hope to show in this upcoming presentation at the AATS, we have found not only really excellent outcomes for patients with oligometastatic disease, we have found that in properly selected patients with disease control and polymetastatic disease, that there is a role for surgical therapy. And even in patients with oligoprogressive disease, as long as all sites of disease can be addressed, there are certain patients that can benefit from local therapy. And so we are finding that even many of the previous exclusion criteria may not be exclusion criteria. But again, a lot of our progress started in the space of oligometastatic disease.